Okay, will do. So patient and family engagement is a very hot topic right now. There's just a lot of energy. You're probably hearing about it from a number of different sources. And what's kind of going on is that there are three different strains of things that we've called patient and family engagement that are coming together. So one of them is work that probably many of you on the line have already done, and that's work around kind of patient rights, sometimes patient rights and responsibilities, the principles of patient and family-centered care. I'm just going to call this our ethics bucket. So there's just kind of a long-standing group of hospitals, group of consultants, group of thought leaders who have really been focused on the principles of patient and family-centered care and how to orient our programs to help instill and embed those principles of patient and family-centered care in everything we do. There's another strain of evidence, really, that's come forward from chronic care and the management of patients who have chronic care needs. And there's quite a bit of evidence accumulated there that shows that if a chronic care patient plays an active role in their own care, they get better outcomes. And then the third bucket is really the bucket around outcomes in general. And, if we bring patients and families into the mix, not only of their own care, but how we design our programs, how we measure what we do, will we see a benefit there in terms of better outcomes overall? And that's what's really gotten CMS's attention. This kind of a dimension of patient and family engagement, they see as a natural ally, a natural piece of the puzzle in the healthcare transformation, payment transformation work that they're really driving through this country. And I'm sure all of you are feeling that. So this is the hack reduction work. It's the readmissions reduction work. It's in that vein of really tapping all of these different parts of patient and family engagement and driving it forward. And the fact that CMS is behind it, I think, is getting a lot of attention. So what are the benefits of it? That's a quick history. The benefits are really that, if you are an organization that's committed to achieving patient and family-centered care, having a council like this is going to help you get there. There's a belief and the evidence I already mentioned from the chronic care arena that says that when patients get engaged, we get better outcomes. So we're hoping to grow that evidence. By we, I mean CMS is hoping, but also we at VHA, all of the organizations that are involved in transformation are really hoping to generate more evidence, and councils are a piece of that. What Armando and I and VHA now have found in our work, because we've done this across the country and frankly in other countries, is that when people come onto a council like the ones that you're going to build, they go back to their community and they talk about it. And they often, people have their own networks, and it really becomes a vehicle increasingly that we're seeing for you growing your reputation in the community or reinforcing and kind of continually generating positive attention to your hospital by engaging the people from the communities that you serve. And then increasingly, there's competitiveness. This should help increase your competitiveness. So I don't know how many of you are already feeling some of the penalties from readmissions targets. I know some of you must be. But anything we can do to improve outcomes, that's where CMS is going. That's where payment is going. And, our kind of true belief, but increasingly fed by evidence, is that patient and family engagement is going to help you get there. CMS is also measuring patient and family engagement for the first time in these transformation programs. And one of the 5 metrics that they're using is, does your hospital have a patient and family advisory council? So by building this council, you're going to be able to pass that metric. And I think from the energy that we're seeing at CMS, these are just the first generation of metrics. So you'll be ahead of the game, I think, in bringing this voice, this resource, creating this resource within your hospitals to really position you well for whatever patient and family engagement metrics come down the road in the years to come, and it's happening rapidly. Okay, so our model for patient and family advisory councils really is focused on partnership, and I'm going to walk us through that now. But it's a little bit different. It's based on the experience that Armando and I have had with, and Victoria have had with our clients. And I keep hitting the wrong button here to advance slides, so I think I'm figuring it out now. So I'm just going to going to do another quick bit of background because some hospitals here may already have councils in place. And councils have been around for a long time, but for the most part they haven't been as focused on safety and quality and outcomes as they have been on patient satisfaction. And that patient satisfaction piece is kind of connected to the principles of patient and family-centered care. And we embrace that. We don't think that's a wrong way to go. But the council can be more of a resource for you than just, helping get your HCAHPS scores up. It can also be a resource for you in really figuring out how to deliver the best care to the community that you serve by bringing them into your policymaking and decision-making process. And what we've found in kind of our trial and error over the years is that the conversation that happens at a council works best if it is a dialogue between people who work in the hospital and people from the community that you serve. So that's why we call it a partnership council. It's a council that really does kind of, we recommend that you open it up to both members of your community and your frontline staff. And by frontline staff, I don't mean people who have patient safety as part of their job description or risk management as part of their job description. I wouldn't exclude those. But what you're likely to find as you get into this process is that you've got people on your workforce. They may not have any clinical responsibilities or any improvement responsibilities. They may be coders. They may be janitors. But they're passionate about their community. They're passionate about seeing your hospital be the best it can be. They've worked there for a long time. They're loyal. I mean, I hope you're picturing people in your workforce that you can think of that just want to contribute. And this is an opportunity for them to engage and contribute as a member of your team. So our model, celebrates that partnership. It puts an emphasis on outcomes. I mean, you can think about the council that we create as almost a place to orient people to the work that you're doing on outcomes improvement, and then harness the wisdom that they bring to the mix, and then use them, distribute them. So our target, Armando's going to talk more about this, is just to build the council as quickly as we can, and then get it to work. An important part of this model, and again, this is sort of through some hard-earned lessons, is that the reporting relationship really matters. This is a council that reports to middle management. It won't be perceived as important as if it reports to some senior management place or the board of directors. And kind of a natural reporting relationship that we're going to recommend that you consider is reporting to a board quality committee or a board safety committee. It's adaptable. We're going to give you some tools that you can adapt to your own needs, but that will be one of our recommendations, just because a council can become a silo. If it's kind of lost in the bureaucracy of an organization, it can become a silo, and we've seen that happen, and people get dissatisfied and they start pressing, and we don't want that. There's also just a lot of interest in the role of the council. Does it actually help us produce better outcomes? And there's a lot of research interest in that. So increasingly we see requests from funders of research to engage patients and families in research work. So if you're doing that, this should position you well to do that as well. This should position you well to be competitive when you go for research contracts or grants. And then I think we've already covered the aligns also with developing federal measures. There are 5 measures, and having a PFAC is one of them. So what do patient and family councils work in? This is just a starter list, and this is constantly expanding. The delight that VHA, Armando, Victoria, and I get to experience in this work, and I should certainly include Natasha, Lisa, and Patty, is that we're just seeing great creativity. Once the councils are built, you can take really any number of issues to them to get their input and their cooperation and participation in tackling that issue. So here are some sort of traditional ones, and I won't read through this. You can just kind of take a list. But there's many, many different ways that you can use this council to work on challenges that you as a hospital face. Keys to success. So personal and leadership commitment is extremely important. We have seen councils that have either not gotten off on the right start or failed altogether because leadership was not engaged. Leadership basically said, do it, to middle staff. They weren't engaged. They didn't provide resources. They didn't continue to support it. They just wanted to kind of tick a box because, again, they thought it was something that they should do for various reasons. But it wasn't really embraced and put into some kind of hospital strategy. So just in terms of lessons learned, this is a really, really key and important one. I keep defaulting to the wrong advance button. So part of this is a journey too. So a council, you'll find it growing in your organization, and part of the growth is just an increasing trust. It really is about trust. It's about getting the right people onto the council. We have tools to help you, I think, really get a group that's eager to help you in the door and on the council. But then it's listening to them, getting to know them, understanding what their issues are, and really growing that trust about what it's safe to talk about, what administration is ready to hear, and it is a journey. So there could be some missteps along the way, and we have kind of a risk management approach, a very constructive human risk management approach built into everything we do. We coach people who are taking us off message versus sticking to the real goal of the council, for example. So just expect it to be a journey. You're going to have a lot of audiences to bring along, including a number of internal audiences. And the journey moves pretty fast, but don't be surprised if you've got some resistance. Is, I guess, the key message of this slide. Council structure and reporting relationships are important. I think I've already covered this. If you don't have a strong reporting relationship, the danger is that this council can just get lost. There'll be parts of your hospital that doesn't even know that it exists. Careful member selection is crucial. So the key to understanding how a council works best is basically teamwork. You want people on this council who share your goals, and the goals are going to be to help your hospital be the best it can be, who trust the process, who get what you're trying to do, including the really complex challenges that you face. This is an opportunity to kind of get your community members, even some of your critics in the community, to understand how hard you are working to manage risk and to deliver quality care every day. I think many people kind of look with hindsight bias, especially after something bad happens, and go, how could that possibly have happened at a hospital? And they don't understand the complexity of what you manage every day, 24/7, no break. The human factors experts, the engineers, tell us there's no other human activity on the face of the earth as complex and as dynamic as healthcare. And complex and dynamic means basically things can go wrong. So you're going to get a chance to transparently demonstrate your commitment to safety and quality with an audience that will, again, go out into your community and talk about it. So our method is appreciative inquiry. I'm not going to go through this methodology in detail. I just kind of put these slides in here in case some of you have already used this methodology. But the core of it is bringing together audiences that have traditionally been kept separate. And I think we have kept, in many ways, patients and families out of our outcomes improvement discussion, sometimes for liability concerns, sometimes just because we don't think they'll understand, because we don't want to share with them our dirty laundry in terms of the challenges that we face. So appreciative inquiry brings audiences that don't typically come together, and it guides them through a process of inventing the future through open-ended questions. So we'll look for people who have experience using your hospital, who have a commitment to having your hospital be really good because they're going to continue to use it or their loved ones will use it. And then we bring them forward, not so much focusing on their own experience, but on what they can draw from their experience to help the hospital be the best it can be in the future moving forward. So it's very future-oriented, it's positive in tone, and this AI approach is built into all of our interviewing techniques, all of our different tools that we're going to give you to help people constantly draw their energy forward. Because if people come on your council and just want to talk about what happened to them in the past or a gripe they've got for a long time, that will just be a drag on the energy of your council. So the process is we look for people who are going to show commitment by taking the time to fill out an application and coming in for an interview. We want to send a message to your community that this is a position of responsibility. It's a position of where they can have an impact, and where we're looking for some commitment and some real intentionality in terms of what they're going to do. And that goes for frontline staff too. And then we'll recruit people who have been users of care. We look for teamwork skills, both a willingness to speak up and a willingness to listen, and ability to generalize from their experience to the experience of others. We look for people who really want to make change, who are positive and think and empowered. And we'll look for the right balance of people too. You don't want a council that's all talkers. You don't want a council that's all listeners. You're going to want a nice blend, and we'll help you do that through the interviewing process. And then we look for staff people who are eager to work with patients and families and eager to grow this resource in their community.